Well, good morning to everyone. I am Dr. Laura Lacher, and welcome to Medical Grand Rounds. We'll begin, as usual, with some reminders and logistics, and then introductions for today. Please be sure to join us next week for a talk on food allergies given by Dr. Shyam Joshi from OHSU. And we are here together at Grand Rounds, now a joint effort between Providence Portland and Providence St. Vincent Medical Centers. We are often here live on Tuesday mornings in Souther Auditorium at Providence St. Vincent at 8 a.m. We are sometimes live at Providence Portland at noon on Tuesdays. You can always watch virtually on Teams Live. The invite for Grand Rounds each week does let you know where we'll be meeting, so you can check out that for details. You can also earn CME credit for being here live in the room, watching virtual live, or watching a recording of the event. That recording is also the same link as the Grand Rounds invite. I'll be monitoring the Q&A throughout today's session, so for those of you online, please go ahead and post any comments or any questions, and I will mostly hold those till the end of the session to ask as time permits. And now for today's introductions. We are joined by Dr. Cody Paiva, a primary care physician with Providence Gresham. He received his bachelor's degree in microbiology from the University of Vermont, and soon thereafter moved here to the Pacific Northwest. He earned his Doctor of Osteopathic Medicine from Pacific Northwest University, and later his master's degree in public health from Eastern Washington University. Dr. Paiva completed his residency in internal medicine at our very own Providence Portland Medical Center in 2023, and his clinical interests include LGBTQ+ care and addiction medicine. In his free time, Cody enjoys running, board games, and exploring Portland restaurants. Thanks, Dr. Paiva.
Good morning, everybody. Thanks so much for having me. I'm excited to be here. Talking about a topic that's really near and dear to my heart. So thanks for letting me just blab on about my passions. So today I'm going to talk about a couple of things regarding overall care for transgender patients. I'd like to talk a little bit about some of the importance from the patient health and public health standpoints, and how the care that we give to these patients can impact health for patients and for communities lifelong. So the objectives include recognizing biases against LGBTQ+ patients in the healthcare setting and how these have negative health impacts, especially on transgender patients. And then the basics of hormone therapy, which I will go over for gender affirming care, will be a case-by-case presentation towards the end. And then I will also review the importance of routine follow-up for hormone gender affirming care, as well as some complications from gender affirming hormone therapy and how to modify therapy as necessary. Now, this is not a comprehensive review of this topic. There are adjunctive therapies, including surgical options, voice therapy, and so on, and those won't be discussed today. I have no financial disclosures. The only other disclosure I have is that some of these medications are technically off-label, as mentioned by the FDA, particularly around the 5-alpha reductase inhibitors for hormone therapy, but they are in standard clinical guidelines for gender-affirming hormone therapy. So in the news, this is a big topic, and I'm sure that we've seen all of this, especially this year of an election cycle. So some examples that we have that are really prominent bills across the country include things such as the Florida's Don't Say Gay bill, which has been passed in Florida as of earlier this year. A lawsuit actually went into place in Florida to kind of specify that it can't be incorporated into a curriculum, but people can freely discuss it. Also importantly, in Idaho, the Supreme Court of the United States has actually cleared that the state of Idaho can currently ban gender-affirming care for transgender youth and adolescents. In Florida also, a bill was introduced called essentially called the License to Discriminate Healthcare Bill, which would allow healthcare providers to deny patient care on the basis of religious, moral, or ethical beliefs. So overall, as of September of 2024, there are 530 anti-LGBTQ bills in the United States, both at the federal and state levels. So this is a very important topic because it is clearly polarizing in the country, but also impacting the health of many different individuals across our country, more so in some other states than others. And this has been a rising topic in the last decade. So, in 2018, as you can see, there were only a few number of bills targeting gender affirming healthcare, and that has skyrocketed in the last few years. Already, this is the beginning of September of this year. There are already 178 anti-trans bills targeting just healthcare alone. This doesn't account for other things such as schools, restroom use, etc. The bias is an important thing. I know that we've all discussed this on our medical training, in our experiences as individuals who navigate the healthcare system or help others navigate the healthcare system. And bias comes both with conscious and unconscious biases, and some of them, such as your unconscious or implicit biases, are things that you may not necessarily be aware of. And the target of talks like this are to help bring this to more of a conscious bias so that you can be more aware of the situation and try and adjust behaviors or adjust your approach to things so that you can better provide care for our patients. The line of consciousness is deep. A lot of our unconscious biases we truly are not aware of, and this is because of our own learned experiences throughout our lives. So we may not know that what we are saying or what we're doing or how we are acting is negatively impacting the person in front of us. And again, it makes it even more important to become more aware of how we are impacting our patients every day through learning and education events like this. Now I'd like to share a couple of stories about bias, discrimination against LGBTQ plus patients that I have experienced in my own medical training experiences, and how they've kind of negatively impacted the health of some patients. When I was a third-year medical student on my general surgery rotation in rural Washington, I worked with a general surgeon who was providing an elective cholecystectomy for a female to male transgender patient. They in the pre-op visit and in the pre-op area before the appointment, the surgeon kept misgendering the patient, who corrected every single time to the point where the patient was crying before we even had started the procedure. This left some mistrust from the patient and making sure that they would get out of this elective surgery safely. In the OR, the surgeon continued to misgender this patient and talk about physical features and characteristics that seemed unacceptable to them and how they viewed physical health and the physical appearance of this person. While I was in residency, as an internal medicine resident, you spend a lot of time doing hospitalist-based work, and in one of my inpatient rotations, I was working with kind of a similar situation where one of my attending physicians actually kept misgendering a patient in front of their face, and the patient actually started to yell and get very upset because it had been very traumatic, and they were there for some very personal and sensitive things. Again, this is a female to male transgender patient who still had female organs and they're experiencing uterine vaginal bleeding pretty significantly, and by misgendering this person, it was worsening their anxiety about being around the healthcare system, as well as they had discussed that it made them feel more dysphoric in their gender. And so it made them feel like they couldn't seek healthcare, and they had delayed their healthcare for many weeks because of this. It's hard to hear, but that's why I'm here talking about it, is because I think we should all care about this, especially in Oregon where we live. There are more LGBTQ plus patients per capita than any other state in the nation at 7.8%. Yeah. Woo. And 0.75% of the population of Oregon identifies as transgender and even more as non-binary. More than half of that population lives in the Portland metro area. Portland has the second highest LGBT plus population in the country behind San Francisco metro area and the sixth highest transgender population in the country. So even if you're not outright, if your patients are not mentioning it to you outright, we do care for a lot of LGBT plus people. And it takes a culture of safety and trust for patients, especially transgender patients, to disclose that to us. LGBTQ plus patients largely do avoid seeking healthcare at baseline due to worry about experiencing bias and discrimination. A study that was done in Sweden over the last decade surveyed more than 60,000 people, where 2% of them identified as LGBT plus. And younger patients in that population were more likely to report physical health symptoms such as palpitations, abdominal pain, nausea, vomiting, diarrhea, and mental health conditions such as anxiety, depression, PTSD, and suicidal ideation because of their worry about bias or discrimination in the healthcare setting. Bringing this back home into the US, one of the largest surveys done for transgender people has been done in the United States, and first done in 2015, called the US Transgender Survey, surveying more than 27,000 transgender people across the country, ages 18 and over. 13,000 people responded, and 8.5% of those people mentioned that they had a primary care provider who knew something regarding trans care. 30% of the respondents did not see a doctor or healthcare provider due to discrimination or mistreatment. 50% of respondents had to teach their healthcare providers about an aspect of trans care so that they could get the care that they needed. 23% report not wanting to seek care due to anticipated discrimination. This survey has been redone and updated, and it was completed in 2022. The data is still being finalized, but the initial update in the 2022 update has surveyed almost 100,000 people. And the numbers are no different in this survey. So almost a quarter of people haven't sought medical care in the last year because of fear of mistreatment. And of those seeing a healthcare provider in the last 12 months, 48% of them have had a negative experience because they were transgender. And again, a quarter of patients were denied by their insurance coverage for hormone therapy, surgery, voice therapy, or other healthcare related treatments related to their gender identity or transition. And this goes beyond the LGBT plus part of the spectrum, and you could think of it in a cross-sectional manner if you're looking at LGBT populations by racial identity. American Indian populations, multiracial populations, and Latinx populations in the LGBT plus community have experienced more refusal to provide medical care based on their race in addition compared to other populations. Gender identity and expression is also an important thing where we see that male to female trans patients have more difficulty getting medical care because of their gender identity and expression. And this has really negative health outcomes for our patients. Male to female trans patients have a higher rate of HIV compared to other groups, and this is also a worry about seeking healthcare, so 20% worldwide. There are higher rates of anxiety, depression, and somatization disorders. These patients are 1.5 times more likely to use alcohol or tobacco, and more than a quarter of them report using substances like alcohol or drugs to cope with their mistreatment, both in the healthcare setting and in the social realm. And the more staggering aspect of this is that trans patients are 26 times more likely to attempt suicide than the general population. Social disparities are nothing that we're unfamiliar with in the healthcare setting. And these affect health of our patients as well. Trans patients are more likely to live below the poverty line. They have higher rates of houselessness. They're more likely to experience bullying, physical assault, and sexual assault. They're more likely to be unemployed or uninsured. And they feel the pressure to present as the gender assigned at birth. But there are some people that are working on trying to reduce these disparities. If you're familiar with the Healthy People Initiative, this is put out by the federal government for the plan for the health of the general population over the next decade. So Healthy People 2030 was put out in early 2020 to address some healthcare disparities across multiple different groups of people. As of the end of 2023, Healthy People 2030 had mentioned that they were working on reducing bullying of LGBT plus high school students, as well as transgender students. You can see that it's been improving for lesbian, gay, and bisexual students, but not for transgender students. That's still in a developmental phase and is still on an ongoing process of trying to essentially figure out how this initiative can help these students. From the mental and mental health disorders realm, there's been no changes in trying to reduce suicidal thoughts, rates of depression, anxiety, or other mental health disorders. And then there's also work on reducing the proportion of transgender high school students who use drugs and alcohol. And again, some of this can be done right here at home. So what can we do as a group of people, as healthcare providers, to help change this and be the conduits for reducing some of these healthcare disparities? There are some protective factors for trans patients. If they have any form of health insurance, this can be protective. If they have a provider who is trans themselves and is open about it, this is very protective for patients. But having a PCP who knows anything about trans care or gender affirming care makes a difference. And then the access to gender affirming medical and surgical care is really important as well. And this has been shown in the US Transgender Survey as well, is that patients who do receive gender affirming surgery or hormone therapy are a lot more satisfied with their quality of life, and they've reduced feelings of anxiety, depression, and mental health disorders. This data, again, is not finalized, but it's showing significant promise that speaks to the fact that as healthcare providers, if we know anything about how to provide care for these patients, then we can make a significant impact on their lives. And then other things, incorporating this into healthcare curricula. Even 4 hours of training improves a medical student's comfort level with approaching trans care, but it's not widely incorporated into the curricula of any healthcare profession. Many providers who do seek this out themselves do so because they're trying to fill an unmet need. They have patients that they are unfamiliar with how to proceed, and they gain those skills independently or through mentorship. And then other things that we can do that make a small impact. Epic will do a lot of work for you. So you can use correct pronouns in the patient chart. Under the sexuality and gender identity tab in the demographics in Epic, you can walk through with your patient to ask them these questions, and it can help them feel a lot more comfortable when they come to see you. And then after you fill this out, it will flag on Epic what their preferred pronouns are, what their preferred sexuality is, what their preferred gender identity is. And then making an effort to remind others that using correct pronouns can make a big difference for other people. And being okay with not knowing. It's okay that we don't know a lot about this. This is not something that has been incorporated into our medical training. It is something that is only coming in to the mainstream of healthcare in the last few years. And so it is our job to be okay with saying, I don't know this, but maybe I can help you find somebody who does. One resource is the GLMA, the Gay and Lesbian Medical Alliance. These are certified providers that you can search by provider to find a healthcare provider in primary care and specialty care who has some experience with gender affirming and transgender care. All of this to be said, let's talk a little bit about how to approach hormone therapy, gender affirming hormone therapy for patients. This can be done. This does not have to be done by a specialist. This can be done by a primary care provider very easily. It is a multidisciplinary approach, though, to help the patient. Primary care providers who are familiar with gender affirming hormone therapy can start therapy, continue therapy, and continue to monitor therapy. And they can work in conjunction with an endocrinologist if available, if questions do arise. Other parts of the healthcare team include speech language pathologists who are familiar with voice therapy, surgeons who can do gender affirming surgeries, such as mastectomies or bottom surgery, and then psychologists and therapists to deal with the mental health aspect can all be really important aspects of care. And these are reflected in our current guidelines. There are two sets of guidelines that are commonly used, and they're both up to date. They've both been updated within the last year. The most easily accessible one is the UCSF Transgender Care. This website is comprehensive and can give you the breakdown of how to approach the initial start to hormone therapy, how to monitor it, what follow-up needs to be done in a very concise manner. If you would like some more significant reading, this thick book called the SOC8 Standards of Care 8 by the World Professional Association for Transgender Health was released earlier this year and is a lot more comprehensive. For the most part in my practice, I do follow the UCSF Transgender Care Guidelines because they're a lot more approachable and palatable, especially in the moment if you need to look up something rather quickly. So I'll run through a couple of cases. This doesn't have to necessarily be interactive, but I would just hope that there are some questions in here and just maybe think to yourself, or if you want to answer, I'm more than happy to answer questions in the moment too. So this first case, A is a 20-year-old non-binary adult. AMAB is assigned male at birth. So that's commonly one of the pieces of terminology that we'll use here, in addition to AFAB, assigned female at birth. So A is a non-binary adult presenting to establish care with you as their new primary care provider. There's a history of depression currently being treated with escitalopram 10 milligrams daily. Their only other complaint is persistent testicular pain with a workup negative for UTI or testicular pathology. They want to discuss with you today feminizing hormone therapy. They have felt since childhood that they've identified more as a female than as a male. Think about what some of the questions are that you would ask this person as you're meeting them for the first time and they've been very forward with you about what they're hoping for. Some of the questions that I like to ask include, how long have you felt that you did not fit your gender assigned at birth? Some people, it can be very transient. Some people, it can be very recent. And in our case here, as A has mentioned, that they have felt since childhood that they have not fit their gender assigned at birth. Then you can ask, what are some specific goals or expectations that you have for starting hormone therapy? As a caveat, pretty much every patient that comes to see you to talk about this has already done extensive research about it, and they have some idea of what they would like to do. This is not like a guideline for hypertension or diabetes where you can follow a specific algorithm, follow a specific number or goal, but rather you follow what your patient's desired physical appearance and expression is. Some things to think about: hair pattern, body fat distribution, breast size, libido, voice. These are all things that patients have mentioned to me are important in changing of their appearance. Do you have any desire or interest at this time to maintain fertility for now or for the future? This is important, especially with patients who are considering gonadectomy. So if they're thinking of removing testes or ovaries, this is something that you really want to make sure of before they undergo any type of gender affirming surgery. And then asking what their support system is like. Who have they talked to about this? Who is supportive in their life outside the healthcare setting? Because it can make a significant impact on the progress they make with their therapy in terms of hormone or surgical therapy, and can help with the mental health aspects. And then, do they have a preferred name or pronoun? Oftentimes people do not want to go by the name assigned at birth, and they've already thought about a name that they would like to try out. And this can be fluid as well. Some people change their preferred name every few months, and that's okay as well. A few things to consider when you're getting a new hormone therapy start. So a couple of criteria that are mentioned in both the guidelines that I've mentioned is a diagnosis of a persistent presence of gender incongruence. They have to demonstrate medical decision-making capacity, and that medical and psychological comorbidities are also appropriately managed. Especially when you're starting hormone therapy, this can impact a lot of metabolic factors, and you would like to make sure that those are actually, you have a plan to manage those, or they are being reasonably managed before initiating hormone therapy. In the past, patients had to require a letter from a psychologist to start therapies. This is no longer widely accepted. You can get a letter of support from a mental health provider confirming gender incongruence, or what's more widely accepted as gender dysphoria, or you can use a shared medical decision-making model where you discuss with the patient the risks and the benefits before starting hormone therapy, and that is sufficient. So what's the difference between gender dysphoria and incongruence? Gender dysphoria is a mental health diagnosis. It is in the DSM-5, and it is more diagnosed by psychologists and other mental health providers. Gender incongruence is something that is a more physical diagnosis and is accepted by the World Health Organization and will be incorporated in the next iteration of the ICD as an accepted medical diagnosis for use when you're trying to bill for your services or send medications in for a patient. Gender incongruence, like I said, is not a mental health diagnosis, so it can be used appropriately for medical hormone therapy. As of the ICD-10 in our current insurance structure, gender dysphoria is more widely accepted and more covered by insurances. So back to A, we're talking about feminizing hormone therapy here. So feminizing hormone therapy, the backbone of this is going to be estrogens and anti-androgen therapy. The estrogen is going to be the most important aspect here, and we'll be using bioidentical estrogens. We're no longer using Premarin or equine conjugated estrogens due to their risk of thromboembolism. It's significantly more increased compared to bioidentical estrogens. Progesterone is not recommended in current guidelines. Anecdotally, some providers do still use progesterone for promotion of breast development, as well as reduction of anxiety or depression or feelings of dysphoria. But there's no clinical benefit that's been proven in randomized controlled trials or retrospective studies, rather than estrogen alone. For other patients, anti-androgen therapy is also important. So this is also more based on clinical experience, and there's no one anti-androgen therapy that's superior over the others. For the majority of patients that I see, I'll start with spironolactone, as this can help suppress testosterone synthesis as well as increase breast development. However, painful gynecomastia can be a side effect that you need to monitor for. In addition, a lot of younger patients under the age of 30 generally don't need an antihypertensive medication, so you need to be very cautious when you're increasing the dose. Current guidelines actually recommend trying to get up to 100 to 200 milligrams a day of spironolactone, and that can be intolerable for a lot of younger patients with lower blood pressures. You can also use 5-alpha reductase inhibitors like finasteride and dutasteride. These can actually help pretty significantly with reducing the issues such as if a patient is assigned male at birth and is experiencing things such as male pattern baldness, this can help improve hair growth in desired areas. There's also medications that we use for prostate cancer, such as bicalutamide, which have had some small studies done for feminizing hormone therapy. One of the common side effects of bicalutamide is breast development. However, there is not a zero risk of fulminant hepatic failure with bicalutamide, so it is not routinely recommended for feminizing hormone therapy. There are a couple of estrogen therapies you can use. The top two up here, the oral and transdermal formulations, are the ones that are most widely available and most widely used. The transdermal therapy is a lot more consistent, as long as the patient is continuously applying an estradiol patch, they can easily get steady state levels of estrogen into their system. The oral estradiol, the limiting side effects are generally stomach upset when taking the medication. As with any medication, starting low and going slow is the name of the game. So starting at a lower dose and slowly increasing over 3 to 6 months can be very reasonable for patients until you get to a desired effect, which I will talk about very briefly. Anti-androgen therapy, as I mentioned, starting low with spironolactone is very important. You're looking out for hypotension as well as hyperkalemia, and so that needs to be part of your monitoring strategy with any dose adjustment with spironolactone. The 5-alpha reductase inhibitors, I prefer to try and use dutasteride because it has greater alpha-1 blocking activity than finasteride, so it can help promote hair growth, especially in patients with frontal or male pattern baldness. So the next thing is really to think about how you're going to monitor this hormone therapy. Both guidelines, UCSF and WPATH, recommend that for the first year of starting hormone therapy, you are checking at least hormone levels every 3 months. And then afterwards, you can check annually or if you make medication adjustments. If you're using spironolactone, then you should be checking at least their creatinine and potassium every 3 months and then annually thereafter. But you're looking essentially at the total testosterone and estradiol levels. For feminizing hormone therapy, goal with a little caveat there is to get the total testosterone less than 55 nanograms per deciliter. And this is an early morning testosterone lab draw. However, some providers choose not to use hormone levels to monitor progress, rather use clinical and physical changes. The Endocrine Society recommends checking levels every 3 months, and so does the UCSF guidelines. However, the WPATH guidelines say that you can use patients' desired for physical appearance as your marker of progress rather than checking serum levels of estradiol or testosterone. When using estradiol tablets at 4 milligrams a day in divided doses, along with spironolactone up to 100 milligrams a day in divided doses, about 2/3 of patients will achieve this desired testosterone level of less than 55. It is not an absolute necessity to get to that level, however. It's also important to talk to the patients about the anticipated timeline for these effects. These effects will take anywhere from 1 month to 3 years to take effect. And there's no exact time frame for any of these things. So some people can get changes in their scalp hair at any given time when they're on feminizing hormone therapy. Voice changes are something with estrogen-based therapies do not occur. So some people will come to you and anticipate that they may change their voice, as in it goes up an octave. This does not happen with estrogen-based therapies. Some complications that you need to be thinking about when you're using estrogen-based therapies. You need to be thinking about their risk of venous thromboembolism. That's an important one, especially when you're giving estrogen. If they're using tobacco at this time, especially with estrogen therapy, discuss with them about tobacco cessation, using medications or nicotine replacement therapy to reduce their rates of complications for VTE. Erectile dysfunction is common as the testosterone level drops down into the feminizing hormone therapy ranges. For erectile dysfunction, you can use PDE5 inhibitors, and they can be used at any time, but they will not help affect libido, and they will not help with obtaining an erection, just maintaining erection. In older women, especially if they have had a gonadectomy, you can consider stopping the hormone therapy around age 50. However, there's no absolute guideline that has to be done. There's no data to support stopping hormone therapy at any age. It's more about the risk and benefit discussion and evaluating their medical comorbidities. And if you're worried about their VTE risk, a transdermal estrogen patch is much less thrombogenic than oral or other formulations. And in the primary care setting, you should be thinking about their routine and health screenings. If they have any form of breast tissue, then they should be engaged in a routine mammogram based on their age and risk, just like a cisgender female. If they undergo bottom surgery and they have a development of a vaginal cuff, you can consider PAPS or HPV screening based on a shared decision-making model with your patient. And if they are participating in anal receptive intercourse, then an anal PAP is recommended as routine screening. For patients on estrogen therapy, and screening for osteoporosis is very important. Some people do get a DEXA at baseline, no matter the age, but screening should start at age 60 and then continue as routine screening from there. In addition, all hormone therapies do have an effect on cardiovascular risk. So estrogen and feminizing hormone therapy does increase HDL. It increases triglycerides. It has a variable effect on LDL cholesterol. So you should be screening your patients for cardiovascular disease risk based on just routine guidelines. So we start A on 2 milligram estradiol tablets and titrate up to 4 milligrams over the first 3 months, and spironolactone 25 milligrams daily, which is well tolerated, but cannot get beyond that level. They're happy with how things are going. As an aside, one thing to make note of that they mentioned was testicular and groin pain. This is something that stumped me a little bit at first, but a lot of trans female patients, if they still have scrotum, testes, or a penis, will either bind or tuck their scrotum and penis, which can cause testicular and groin pain, which can be often thought of as testicular torsion, varicocele, epididymitis, or a urinary tract infection. Let's move on to another case. So Jay is a 50-year-old transgender male assigned female at birth who presents in follow-up to you. He's been on testosterone therapy for 16 years and is currently using transdermal testosterone gel at 5 grams a day with very few missed doses. He's not undergone any gender confirmation surgery, but does use a chest binder. Past family history includes an MI in his father at age 55 and breast cancer in the mother at age 70. He's asking about transition to injectable testosterone as well as what specific cancer health screenings he should undergo. So let's talk a little bit about testosterone therapy for masculinizing therapy. So Jay is using 5 grams of testosterone gel, which is highlighted here as a 1% formulation. There's also a 1.62 formulation, which is noted below. 5 grams of testosterone gel at 1% is equivalent to 50 milligrams per day of testosterone. The preferred regimens that we're using currently include the testosterone gels at the 1 and 1.62%, and then the testosterone cypionate, which can be given as a subcutaneous or an IM injection. And this is highly variable. While the gel is at once daily application, the testosterone cypionate injection, just like you would use for male hypogonadism, can be on an every 2-week schedule and plus or minus 1 to 2 weeks on that. There are some patients who do 1 injection every 4 weeks, while others need to do 1 every week to maintain testosterone levels. Testosterone therapy is the backbone of masculinizing therapy, and routine monitoring is pretty minimal compared to estrogen therapy or feminizing hormone therapy. It's recommended to monitor the total testosterone, again, every 3 months for the first year, and then you can do annually afterwards. You should also be monitoring your patient's blood counts, particularly the hematocrit, in the first year of starting masculinizing hormone therapy. And I'll talk more about that in just a moment. Testosterone is a finicky hormone, and you need to test it in variable ways based on the type. So if you're using cypionate injections, your blood draw needs to be first thing in the morning, ideally before 10 a.m., and it needs to be midway between injections. So if they're on an every 2-week schedule, on that off week is when they should be getting their blood draw. Decanate is a newer formulation of testosterone, which is much longer acting, and you measure the level just before injection. For testosterone gel, they need to have been on the current dose for at least 1 week, and then you check the level 2 hours after the last use. Ideally, again, first thing in the morning before 10 a.m. And anticipated timeline for effects is the same, is very similar for masculinizing therapy as it is for feminizing therapy. The onset can be many years beyond the start of hormone therapy. The major difference here is that you may notice deepening of the voice with masculinizing therapy over the first year, and it can progress into the next couple of years. Complications. So some people who still have a uterus can have persistent menstrual bleeding. This usually stops in the first few months of testosterone use. This is the only time where oral progesterones are recommended, is if they have persistent menses or bleeding, you can consider an oral progesterone to help manage the menses while the testosterone is getting to an optimal serum level. Polycythemia is an important complication of testosterone therapy, and you need to consider dose adjustment of your testosterone if the hematocrit gets above 50, because you're at risk of venous thromboembolism, clotting, and cardiovascular risk. Hormone therapy, again, Just like with estrogen, with testosterone affects triglycerides, so routine evaluation for cardiovascular disease is recommended. With testosterone therapy, we'll see patients have decreased HDL, increased total cholesterol and triglycerides, as well as increases in LDL cholesterol. There have been some studies to ask about other metabolic effects of both feminizing and masculinizing hormone therapies on things such as glucose or the risk of diabetes. Some small studies that have been done in Europe haven't shown any increased risk of prediabetes or diabetes in patients undergoing hormone gender-affirming therapy. And then age-appropriate screening. If a patient has any breast tissue, you should consider routine mammograms based on their age and risk. If they are post-mastectomy, you can consider sub or periareolar breast exams. This can be done by self-exam, or you can offer breast ultrasound or MRI for routine screening. If they still have a cervix, they still need routine pap smears done at routine intervals. And then osteoporosis screening. So for bone density screening, if testosterone therapy is discontinued for any reason, despite age, you should obtain a DEXA to screen for osteoporosis. So J transitions to testosterone cypionate and a subcutaneous injection at 100 milligrams every 14 days to good effect without any changes to physical appearance. Follow-up mid-cycle injection, the AM testosterone is 350. The goal is generally to try and be between 400 and 700. So from here, you could consider increasing, or you could ask J if they feel comfortable with maintaining at this current dose and current level. If they're feeling their physical appearance is maintained or is at their ideal situation for the current time, that you can continue even though it's not at the recommended 400 to 700 AM testosterone level. All right. Next case here. This is S, a 45-year-old transgender female assigned male at birth who's seen for a preoperative visit for elective total right knee replacement. The orthopedic surgeon has sent them to the primary care office for a pre-op clearance. And they're asking to see if the estrogen therapy needs to be discontinued because of the risk of blood clotting with orthopedic surgery. S is distressed about this. Stopping estrogen therapy, even for a few days, has them worrying about changes in their appearance and reoccurrence of their feelings of gender dysphoria. She's currently taking estradiol tablets, 2 milligrams daily without any missed doses, no history of malignancy, no tobacco use, no prolonged immobilization, no VTE risk. How do you proceed with estrogen treatment? Well, the first question you ask is there any data to support an increased risk of VTE with estrogen therapy? With bioidentical estrogens, the risk is pretty minimal compared to the general population. We're not using Premarin or conjugated estrogens. So there's no data to support stopping estrogen use in someone who has no risk factors for VTE. It may be slightly higher in transgender women, 3% compared to the general population, but no strong data supports stopping altogether. Theoretically, you could offer transition to transdermal estrogen because it is less thrombogenic. That could be considered perioperatively if desired. Otherwise, the patient will probably receive some form of DVT prophylaxis perioperatively, and this can be sufficient to cover, particularly if they get admitted to the hospital. There are a few options on how to proceed. You could stop the estrogen altogether 2 to 4 weeks before the procedure, but there's a risk of hypoestrogenism and distrust from your patient and disdain from your patient. You could reduce to 1 milligram daily to reduce the VTE risk without hypoestrogenism risk. You can continue at the usual dose or offer a transdermal estrogen. In this case, I just recommended that they continue at their usual dose because if you have a risk and benefit discussion with your patient and the risks of stopping estrogen therapy are much greater, especially from a mental and physical health standpoint, than the slightly increased VTE risk, and the patient understands this risk, it's reasonable to continue the estrogen dose. My last case here is a spin on case number 3. This is an in-the-hospital consultation by an orthopedic surgeon who is on the same patient, a 45-year-old transgender female who is found to have a DVT in the left lower extremity on post-op day 3 from a left total knee replacement. The surgeon stopped the transdermal estrogen, but would like direction on how to proceed. Again, no history of tobacco use, immobilization, malignancy, VTE. The family history is unknown as the patient was adopted. Well, fortunately, the UCSF guidelines have some little bits of information on how to manage complications, particularly around VTE in patients with a history of VTE. So in this patient, they have no prior history. So in this case, you could consider prothrombotic mutation evaluation to look for evidence of some other hypercoagulable state, such as cancer or a genetic mutation. If there's no risk for that, and there's a clear external cause, in this case, a surgical procedure, you can actually resume the estrogen therapy once the external cause has been resolved. So in this case, you could offer treatment for the DVT and continue the estrogen therapy, which is what many people choose to do, where they'll, even though it is the first DVT, they will treat for 90 days and then continue the estrogen therapy concurrently. You can offer to stop the estrogen therapy altogether, but again, that's a risk-benefit discussion that you should be having with your patient. Or you can this person had been on transdermal estrogen, so the other reasonable option is you could be doing a more intensive prothrombotic mutation evaluation. In this case, the patient was continued on their estrogen therapy and treated for 90 days for their DVT with complete resolution. So in summary, social and health disparities amongst transgender patients are very significant. They often result in discrimination and fear of mistreatment. Our biases do play a significant role as a hurdle to getting appropriate care for trans patients. Access to care, having any knowledge about any aspect of trans health, and creating a culture of safety are key to help with patients feeling comfortable or receiving gender-affirming care. I've reviewed a little bit about the basics of starting a new hormone therapy, transitioning from one method to another, and managing some complications. Again, this is not a comprehensive review, but as I've mentioned, the UCSF guidelines and the WPATH guidelines have a lot more extensive information about this. And if you have any questions at all, Providence has an e-consult service for trans care, which you can order in Epic. All the providers that answer the e-consult service are incredibly responsive and can be very helpful. I'll take some questions now. Thank you all for your time.
Great, thank you so much for your talk. Happy to take any questions in the room to get us started. Well,
Hi, thanks so much. Excuse me. I am curious. I feel like our treatment goals are sort of different than in most of the rest of the medicine we do, where we are setting the treatment goals. And with these folks, they are setting the treatment goals. And so I feel like that's like a little bit of a paradigm shift. And sometimes their previous prescriber has been somebody that we don't know and we're not necessarily so comfortable with, such as a naturopath. And so how do we bridge that, them coming in on whatever regimen they're on, and then us taking ownership moving forward?
Great question. I think the first thing it really comes down to is safety. Is the regimen that they're coming to you on, is it a safe regimen? Is it within some of the minimum maximum dose treatment guidelines? If that's the case and they don't have any evidence for complications, examples, they're on testosterone therapy and they're on 300 milligrams IM cypionate every week and their total T level is 700, 800, that's quite reasonable. And they don't have an elevated hematocrit, their cholesterol is reasonably controlled. That is reasonable to say, okay, that's reasonable to continue on, especially because are you getting the desired physical appearances that you're hoping for? For some patients who come in and they're on massive doses of medications, or they're on medications where there's no data to support, so equine estrogens, progesterone therapy, you can talk with your patient and say, hey, there's not a lot of data to actually support that this is making much of an appreciable difference on, one, your physical appearance, and two, the actual hormones that are in your body. A lot of the patients that I've treated who have come in on regimens that I have not started, the first thing I'll say is, hey, let's check some blood work first to make sure that you're actually like in a safe range to continue these medications. And there's a level of trust there as well. So patients are going to be obviously mistrustful at first when they're transitioning care, because this is a very sensitive subject and there's a lot of worry about you taking away something from them. So I frame it as more from a safety standpoint, and that helps a lot of patients to understand that this person actually cares about me, not just from the hormones I'm taking, but also from my global health.
Great. Well, we ponder other questions in the room. One about monitoring of testosterone levels, and specifically on the transdermal formulation. So you commented on checking 2 hours after last dose and yet before 10 a.m. in the morning. Practically speaking, how do you troubleshoot that in your practice, and how much does that timing, which might be challenging, matter?
The timing is really helpful because of the wide variability of testosterone throughout the day. And so there's a lot of variability in the levels of testosterone consistently. So the goal ideally is to mimic a cisgendered male's testosterone diurnal variation. And so checking it before 10 a.m. just gives you the most accurate generic reading. For some patients, I will say, if you can do it before 10 a.m. and if you can get up early and put your transdermal tea on, then great. If not, we'll modify as we're able to. Again, these are not hard guidelines. Like, we're not meeting an A1C goal. We're not meeting a blood pressure number. We're meeting to try and say, okay, are we meeting the physical appearances and your desired appearance? And even if we aren't following the specific 2 hours after application before 10 a.m., it's reasonable to continue. It's very fluid. That's the hard part about this. So.
We do our best.
Yes.
Great. Another comment and question from here online. First off, thank you for a lot of helpful information. They were wondering if you would walk us through a little bit more about how to make the diagnosis of gender incongruence, and then maybe specifically also strategies for talking with and engaging family or other support systems that the patient would like to involve in their care.
Great. So the diagnosis of gender incongruence, technically, per the WHO's description, is a persistent feeling of a person's expressed sensation of a gender does not match the gender assigned at birth, and it's approximately 6 months of feeling that way. A person can come to you and say, I've been feeling this, I'm not entirely sure how long, and you can ask them, you can try to pull out a little more of like, oh, was there an inciting event that helped you realize that this, that you didn't feel like you're the gender assigned at birth. So sometimes I'll ask people to kind of reflect on that a little more of like, was there a traumatic event? Was there a significant event in your life? Maybe it wasn't traumatic. Maybe it was an amazing experience that they've had. So the 6-month mark is generally where we hope to get to. Again, it's very fluid. There are some people who come in and they say, I've been feeling this way for the last couple of, 2-3 months, and I'm very certain of it. And in that case, you're using a shared medical decision-making model to say, okay, there are risks and benefits of starting gender-affirming hormone therapy. And if the patient is willing to proceed with those, despite not meeting that 6-month mark, it's still reasonable to do so. As far as engaging family members, I always start with the question of like, what does your support system look like? Who's at home with you? Just to feel out the dynamic of the family that they're with or the people that they're with, and then ask them who is, if they can name one trusted person in their life, who would that be? If you start with one person engaging, outside of the patient and myself, then that can really open the doors to helping with other family members garnering support. With that one person that they identify, if they've told this person, then that's a good first step. if they haven't told this person, they haven't come out saying, you know, I don't feel like I'm a male or a female, I'm something different. I'll often refer to a psychologist to kind of talk through some of the hurdles there, because coming out is a deeply personal thing. And I'm not going to ask them to bring that person in to say, it's time for you to come out to your friend or whatever, your family member. So finding that one person of trust and saying, if you haven't come out to them, what are some of the hurdles, or do you have a time frame, or do you have an idea of how you would like to do that? And if they don't, then working with their mental health provider, their therapist, to kind of work through some of that is really helpful. For some people, I've had some people who've had, they say, I don't have anybody in my life who I can feel I can trust or support. I'll sometimes ask them to, you know, look for support things online. You can look at things like, I mean, there's no medical validity to it, but like Reddit, you know, if they have some worried experience, they can, maybe they'll read a story online that will be a way for them to feel more comfortable about who they are as a person, who, you know, trying to figure out who they could come out to, how they should feel safe. And this all boils back down again to safety. So a lot of adolescents and a lot of younger patients are maybe still living with families and are in fear of getting evicted, kicked out, disowned by their family. So I rely on a lot on mental health providers, as well as them identifying a person of trust first.
Thanks for this. I'm kind of following what Emily said and thinking about some patients in my practice who have some fairly serious medical conditions where I, as the doctor, do not want your potassium to be 6, and I do want you to take your diabetes meds. And I realize sometimes you take and sometimes you don't take your spironolactone, which, by the way, is helping with your hypertension that I care about. And I'm just curious if you found ways to work with patients. I think my experience is folks who are not feeling well mentally can't really manage diabetes. And so I have kind of tended to just work with the gender piece, but I struggle when I see that A1C of 10 and we have scrotal cellulitis or other serious complications that need to be managed. So,
yeah,
free consult for me.
Tough one. I do very much agree with you with focusing. It's one big thing I do in my practice a lot is harm reduction, right? Like you may not be able to get that A1C goal in, you know, under 8 in your desired time frame, but if you can help them feel more comfortable in their body and their physical appearance by managing their gender identity and expression through hormone therapy, that can make a world of difference for patients and open up, 1, trust from you, 2, it can open up their motivation or maybe where they are mental health wise to help manage some of those comorbid health conditions. I have one patient who did not exercise at all until after we started masculinizing hormone therapy, and he got a mastectomy for breast removal. And he, after getting the mastectomy, said, the reason I wasn't exercising is because I hated wearing a sports bra, I hated looking at my breasts, I hated how it felt, and now I feel like I can actually do something like that. So by approaching just the hormone therapy, you are already doing harm reduction for that patient. Maybe not necessarily from a diabetes standpoint, but from a mental and physical health standpoint, it can make a world of difference.
Small question, and I'll allow myself a big comment. First, the big comment. A little bit, just a slight bit of history of my own training, medical school in the late 80s, UCLA Medical School. I had superb training in psychiatry, but at that time, the presentation of people who were transgender was that it was among the worst things that could happen to a human being in the world of psychiatry, worse than schizophrenia, high rates of suicide. There was essentially no awareness of the time that that suffering was mostly externally imposed, and we've come a long way. So that's my big comment. Small question. One of your slides, I thought, implied that people who had a reconstructed vaginal cuff might need PAPs and HPV testing? I don't understand that.
You know, it's one of those ones that I've also kind of grappled with, but it's part of some of the WPATH routine screening guidelines is saying that they should consider routine vaginal or vaginal cuff pap smears. I don't know actually like a lot of data behind it, but it is part of a general recommendation. I don't have anything beyond that besides some of the guidelines say it. So that's a good thing to look into, though. I have to do a little more reading.
Great. We'll take one last question right at 9 o'clock, and then we'll wrap up.
Hey, thanks, Cody. One thing I've kind of struggled with is the follow-up on physical characteristics. I'm trying not to impose my own judgment, but yet we're like talking about things like hair growth, et cetera.
Mm-hmm.
How do you navigate a conversation with a patient regarding like their change in physical characteristics
Mm-hmm.
without, you know, putting your own judgment into it too?
Mm-hmm. I always start with, how are you feeling? How do you feel like you're meeting your goals in physical appearance? Do you feel like you look how you want to look in terms of, and then I also discuss that there are, of course, some limitations on what the hormone therapies can do. So I don't, because especially so in some of the guidelines with non-binary patients who are not saying, I want to look exclusively female or I want to look exclusively male, they're saying, I'm falling somewhere on this spectrum. It is a lot of up in the air and just saying, do you look the way that you're hoping to look from these medications? And just by knowing in general, like, oh, okay, well, voice deepening, for example, on testosterone therapy, it can take up to 2 to 3 years for you to actually get to the full deepening of a voice that you could experience. So at 6 months, 1 year, they can be like, oh, I don't feel like my voice is as deep as I want it to be, or I'm experiencing, you know, I haven't had hair regrowth from my estrogen therapy, and I'm wondering what else to do about that. A lot of patients, after you've seen them a few times and developed trust, if you just say, do you feel like you are presenting the way that you're hoping to, they'll be very honest and say, no, I was hoping more for this, or what else can we do about that? And that's where you can kind of get creative about things. You can add topical minoxidil, you can send to a speech language pathologist for voice therapy, you can send them for, you know, or recommend laser hair removal, you can recommend seeing a plastic surgeon. Like there's a lot of openness to it. So I just am more flat out. Are you feeling that you're presenting the way that you're hoping to?
Great. Thank you so much for a wealth of information, broad topics and details. Lots covered. Thank you.
Thank you.